spent quite a good amount of time just talking about inguinal canal and inguinal ligament. And to start with, we started with the anterior abdominal wall muscles. As we know, we have anterior abdominal wall muscle, external oblique, internal oblique, and transversus abdominis. They are on the side, they are muscle, and once they get closer to the center, they get closer to the center, they become aponeurosis, and below the level of arcuate line, I believe you remember arcuate line, it is the, let's say, midway between the umbilicus and the pubic symphysis, midway. At that level, all these muscle fascia aponeurosis go in front of the rectus abdominis, and only the transversalis fascia is running posterior to the rectus abdominis muscle. And these anterior abdominal wall muscle, they try to attach to the groin region and pubic region, and by doing so, layer after layer after layer, and they are trying to, they create a canal. Inside the canal, we have spermatic cord in male and round ligament in female. Round ligament is just like a cord, tube-like structure. There is no special structure inside, so it is not that important in female. But in spermatic cord in male, like we have vas deferens and artery to the testes, and all sort of important structures run inside the spermatic cord, and therefore spermatic cord is important, which means that the pathway the spermatic cord is running, which is the inguinal canal, is also important for us. So yes, this is the groin, right side, left side, testicles in the scrotum, right testicles, left testicles. Hey, testicles, two testicles in one scrotum. They cannot touch each other because there is a septum in between the right and the left testicles. So the right testicle and left testicle, although they are very close, they cannot touch each other. There is a partition which is called septum. And if you look at the external oblique muscle here, external oblique muscle, look at that. On like anterior and laterally, it is more of a muscle. It will become aponeurosis in the center and meet with the opposite side at the linear elbow. If you look at that, this external oblique will come and attach to the anterior superior iliac spine. And as I say, it just roll and curve when it gets to the edge, which forms the inguinal ligament. So inguinal ligament is the same as external oblique aponeurosis. It is the lower edge fiber. So this is the external oblique aponeurosis. The lower edge fiber, the carlap, the lower edge fiber become carlap, and this curved and dense, this curved and dense layer is called the inguinal ligament. So this inguinal ligament, as we know, like attached to the anterior superior iliac spine, and medially its fiber split and like an arch, and they come attached to the pubic symphysis and the pubic tubercle. By trying to split an arch and attach, it creates a little aperture, which is like a V shape, inverted V shape, and that is what we call the external ring. So this external ring is going to transmit the spermatic cord, and it will run along the inguinal canal. Yes, if we keep looking at that, that's what I was drawing here. This is the pubic tubercle, this is the pubic symphysis, this is the anterior superior iliac spine, and this is the muscle and aponeurosis of the external oblique, and which come and join like that and forms the inguinal ligament. And when it is trying to attach as an inguinal ligament and to the pubic tubercle, its fiber split like a V shape, and we have a little window or aperture, or this is what we call the external ring of the inguinal canal. And let's say, if we look at that here, so this is the anterior superior iliac spine. This is the pubic symphysis. This is the pubic tubercle. This is the inguinal ligament, external oblique aponeurosis, and the V-shaped opening gap through which the spermatic cord or the round ligament comes out. So let's say if I remove the external oblique muscle here, then if I just remove it and flip it down, I can see the internal oblique muscle here. Internal oblique is attached to the inguinal ligament on the lateral 1/3. So not middle 1/3, not medial 1/3. Internal oblique is originating from the anterior superior iliac spine, iliac crest, and lateral 1/3 of the inguinal ligament. And it's just run like a dome shape. It's just run like a dome here, run like a dome here. And then it just ran over the spermatic cord, and it can attach, go to the posterior. On the lateral, it is anterior to the spermatic cord, and then on the medial side, it reached the posterior aspect of the spermatic cord and go and attach to the pubic tubercle. And now we can see the external oblique here. Posterior to the internal oblique, we will see the transversus abdominis here. This transversus abdominis will form the posterior wall and also to come and join the internal oblique aponeurosis. And these two combination is called the conjoint tendon. So now I am going to remove the internal oblique muscle, which is colored with green, and this is what happens. So this is the leaflet of the external oblique aponeurosis, which I have flipped it down. Now I have flipped down the lateral 1/3 anterior to the spermatic cord. So now I can see the whole spermatic cord here, and this external oblique, internal oblique, which is colored with green, which normally runs above from lateral anteriorly to the medial posteriorly of the spermatic cord. Now I can see the whole spermatic cord, and I can see the medial fibers of the spermatic cord, which is going to fuse with the transversus abdominis muscle, and this is called the conjoint tendon. So conjoint tendon is nothing more than the fusion of the internal oblique and transversus abdominis. So what are the boundaries of the inguinal canal? Anteriorly, as we see, like, external oblique and internal oblique in the lateral 1/3. Posterior wall, transversalis fascia, don't get confused with the transversus abdominis. Transversalis fascia is just outside the peritoneum. Internal oblique and conjoint tendon. Conjoint tendon is the combination of the internal oblique and transversus abdominis. So conjoint tendon is on the medial 1/3 of the inguinal canal. And the roof, of course, we see the arching fibers of the internal oblique and some fibers from the transversus abdominis. Yeah. So some fibers from the transversus abdominis and the arching fiber of the internal oblique that will form the roof. And the floor is the inguinal ligament, as we can see here. Floor is the inguinal ligament. Lacunar ligament, iliopubic tract, these are just the dense layer of the continuation of the internal oblique aponeurosis. So all these ligaments, inguinal ligament, lacunar ligament, iliopubic tract, these are just like, depending on their portion, they are just a continuation of the external oblique. This inguinal ligament is also the inward folding of the external oblique. Lacunar ligament, again, like a folding of the external oblique. And iliopubic tract is going from the ilium to the pubic. It's again the same. It's all like external oblique. So superficial ring, we saw that it is in the V shape. It is in the V shape opening of the external oblique. And it is just superolateral to the pubic tubercle. So this is the pubic tubercle. It is superior and lateral to the pubic tubercle. So what we need to know is the external ring of the inguinal canal is just superior and lateral to the pubic tubercle. So when you see a patient with the hernia, you can see an inguinal hernia in the inguinal region, and you have to know where this herniation is through the external ring or not through the external ring. So you should be able to identify the site of the superficial inguinal ring. So what I want you to do is just try to identify the landmark of the pubic symphysis on yourself and just trace and follow, and you will feel a little bump. You will see a little bump on the close to the pubic symphysis, and just above and lateral to your pubic symphysis here, pubic tubercle here, you should be able to feel the superficial inguinal ring. So yeah, that's important. And deep ring is in the transversalis fascia, so which is not the external oblique, internal oblique, transversus abdominis, and the opening in the transversalis fascia. Yeah, so you remember the transversalis fascia. And where it is it in the mid inguinal point? So hey, so I have written here too, midpoint of inguinal ligament and mid inguinal point. So they are different. Yeah, so midpoint of inguinal ligament and mid inguinal point, they are different. So let me show you again. Let's say, so this is the anterior superior iliac spine. This is the pubic tubercle. This is the inguinal ligament. So midpoint of the inguinal ligament is here in the middle of the inguinal ligament. But mid inguinal point is about 1 inch or ½ inch, 1 centimeter, 2 centimeter above the midpoint of the inguinal ligament. So mid inguinal point and midpoint of inguinal ligament are different. Midpoint of inguinal ligament is at the middle of the inguinal ligament, and mid inguinal point is about ½ inch or 1 or 2 centimeter above the midpoint of inguinal ligament. So yes, of course, you know, like depending on the body habitus, it might change a lot. But just there, we have the deep ring of the inguinal canal. And deep ring is the entrance into the pelvic cavity, and superficial ring is exit from the pelvic cavity along the inguinal canal and going into the scrotum. So these are the important anatomical sites of the inguinal canal. So why am I talking too much about this inguinal canal? Of course, as we say, you know, we have important structures in the inguinal canal. In male, we have the spermatic cord, and in female, we have round ligament. So round ligament is just a big, thick ligament, so which is not really an important structure. I mean, we can cut the round ligament and nothing would happen. But in male, we have spermatic cord, and spermatic cord has many important structures, and we should know what the spermatic cord is made of. So the contents of the spermatic cords, we always try to remember 3 arteries. So testicular artery. So as you remember, testicular artery arising from the anterior surface of the abdominal aorta, 1 on the right, 1 on the left. Gonadal arteries, I believe you remember, like after the renal artery, then coming down superior mesenteric, then testicular artery, then inferior mesenteric. So testicular artery is from the abdominal aorta, and it has to go through the deep inguinal ring, go around the inguinal canal, come out from the external ring of the inguinal canal, and go into the scrotum and give blood supply to the testes. Hey, it is, it is a long way. This testis has to take blood from the abdominal aorta, which is such a long. Why this happen? Of course, during the development, the testes, they are in the abdomen. And with time, the testes gradually go down out of the abdomen through the inguinal canal, go into the scrotum. So that's why the testes, which was embryonically in the abdomen, with the development, it has to go into the scrotum. Therefore, it pulls the blood supply with it, and therefore this testicular artery has a long way, and it has to go through the deep inguinal ring, inguinal canal, superficial inguinal ring, and go into the scrotum. So that's that one testicular artery. And artery to the vas. Hey, I believe we will see that in the later diagrams. I believe you know the vas deferens. So this vas deferens also needs blood supply, and this artery to the vas is also in the spermatic cord. And cremastem, we have a muscle called cremastem muscle in the scrotum, and this cremastem muscle is supplied by the cremastic artery, and this cremastic artery is also in the spermatic cord. So that is important. So these arteries, if we block any of these arteries, the testes, if we block the testicular artery, the testes will get damaged. So we can do that. So testicular arteries, artery to the vas, and cremastic artery, they are all inside the spermatic cord. Hey, on top of that, we have the vas deferens. We have the vas deferens inside the spermatic cord. We have the lymphatics in the spermatic cord, and we have the pulpiniform plexus of vein in the spermatic cord. So this pulpiniform plexus of vein is the venous return from the testes back into the inferior vena cava. Of course, the testes, the veins from the testes, they form as a venous plexus, which is called pulpiniform plexus of vein. And then this pulpiniform plexus of vein finally will combine and merge and run as a testicular vein. So before it became testicular vein, this venous plexus is called pulpiniform plexus of vein. So this vein is also running inside the spermatic cord. And we have the vas deferens and we have the lymphatics. That's not the end. We also have sympathetic nerve, parasympathetic nerve, and genital branch of genitofemoral nerve. So these, all the nervous structures are running in the spermatic cord. And therefore, spermatic cord is important. Therefore, we have to know the anatomy of the spermatic cord. And the anatomy is the spermatic cord is running inside the inguinal canal. And therefore, the inguinal canal anatomy became important for us. So yes, content of the spermatic cords is a little bit important. Just don't memorize it, but just think again and again and again, because the spermatic cord is connecting the pelvic structure into the scrotum, and therefore, what structure do you want going into the scrotum? And you have everything here in the spermatic cord. So now we got to talk about this reproductive system, because the name of the lecture is reproductive system, and I was talking about the basic embryology. I was talking about the basic anatomy of the inguinal region, and now we start the reproductive system. So reproductive system got mature only after the puberty. So like our brain, when we were newborn, like a little newborn baby, our brain is not fully mature yet, but within 2-3 years, the brain is fully mature. That's it. This is it. Like our gastrointestinal tract, it will become larger and larger, but the gastrointestinal tract is fully mature already when we were born. Our reproductive system, like our ovaries, testes, uterus, external genitalia, they were not fully developed when we were born. And even we were childhood, like when we were 10 years old, they were not fully developed. So this came only, this reproductive system itself became mature only after the puberty. So that is one strange thing about this reproductive system. And its function is to, of course, produce offsprings. And we need to know what is the primary sex organ and what is the accessory sex organ. So primary sex organ is only one thing, testes in male and ovaries in female. That's it. So let's say if you become working in the obstetrics department, might be a midwife or as a doctor or whatever you do with the obstetrics. And when a little baby is born and you deliver a little baby and you look at their external genitalia, and it doesn't look like a male, it doesn't look like a female, a little bit ambiguous. So these things can happen, which is ambiguous external genitalia. Ambiguous external genitalia mean, hey, what are we going to do? Is it a baby boy or is it a baby girl? Who knows? So what we need to know is we need to identify whether this little baby has testes or ovary. So that is really important. Whether the external genitalia looks like scrotum and the penis, but if that little scrotum and penis do not have testicles inside the scrotum or in the abdomen, then that baby is not a boy, because it is genetically, it is female, because there is no testicles. The same thing, like if the external genitalia might look like, oh, a little bit female, but if that baby has got testicles, then we have to appreciate this is a genetically, it is a male. So this ovary and testis determines, or this primary sex organs determine whether he is a boy or a girl. Of course, if we have to do karyotyping, like is it 44XX or 44XY? So we have to try to understand that now. But if the testes and ovaries determines whether we are a boy or a girl, and these are the primary sex organs. And the job of the primary sex organ is to produce spermatozoa in male and ovaries in female. And also their job is to secrete sex hormone. In testes will secrete androgen, especially testosterone, and ovaries will secrete estrogen. So that's this estrogen and testosterones, they will go directly into the circulation, and therefore they are endocrine glands. So the testes and ovaries will serve as a endocrine function as well as the reproductive function. What are the others, like accessory sex organs? They are external genitalia, the penis, scrotum, the vulva. These are all external genitalia, and they are just the accessory or secondary sex organ, or the glands in and out around the genitalia or the ducts here, there, they are just secondary sex organs. So what is important is primary sex organ, which is testes and the ovaries. Right. So this is the male reproductive system. So let's start here. Penis, testes, which is in the scrotum. Look at the scrotum. Inside the scrotum we have testes, and testes is whitish color, and you can see a little hood which is covering just posterior and lateral aspect of the testes, which is elongated, which is enlarged at the top superior pole of the testes, but gradually becomes smaller and pointy at the inferior pole of the testes. That is what we call epididymis. So the testes, inside the testes, all the tubes inside the testes will drain into the epididymis, into the head portion. And that testicular secretion, which is semen, sperm, will continually track down along the head of the epididymis, body of the epididymis, and tail of the epididymis. And finally, the tail of the epididymis became the vas deferens. Hey, this is the vas we were talking about. So artery to the vas and the vas deferens, they are inside the spermatic cord, which is running in the inguinal canal. So look at that, from the testes inside the scrotum, this vas deferens is running and going into the external ring of the inguinal canal, along the inguinal canal, through the deep inguinal ring, and get into the pelvic cavity. It ran close to the urinary bladder here. Look at that, gradually it became dilated, which is called ampulla of the ductus deferens. And here, when it comes into the prostate, it joins with another duct, which is coming from the seminal gland. Look at that, seminal gland. So seminal gland duct and the ductus deferens, they join together to form the ejaculatory duct. Look at that now. This ejaculatory duct, look at the bladder here. The bladder, from the bladder, our urine passage, which is called urethra. Urethra is coming from the bladder, going through the prostate gland. This yellow orangey color is prostate gland, going through the prostate gland. Inside the prostate gland, it is called prostatic urethra, and it passed the marcellia here. You can see the marcellia, which is called urogenital diaphragm. And then urogenital diaphragm, and then you will come out into the base of the penis, along the root of the penis and along the body of the penis, and come out to the external urethral meatus or external urethral orifice. Look at the root of the urethra, U-R-E-T-H-R-A, urethra. So urethra has to go through the prostate here. This is the yellow orangey color is the prostate gland. From the bladder, urethra will go through the prostate gland, pass through the marcellia, which is called urogenital diaphragm. And the portion of the urethra, when it is passing in the marcellia, is called intermediate part of the urethra. And now it comes out into the base of the penis, body of the penis, and then gradually come out as the external urethral meatus. And this is what we call the spongy urethra. So the male urethra has three portions now, and into the male urethra, this ejaculatory duct, which is the combination of the vas deferens and the duct from the seminal gland, we join as the ejaculatory duct, which we join into the prostatic urethra or prostatic urethra. So that is the passage. So when we talk about the sperm will be formed inside the testes. And then once there is enough sperm is formed, it will be stored in the epididymis. So epididymis is for the storage of the sperm, and it will make the sperm more and more mature. So inside the sperm, inside the testes, the sperms are not fully mature yet. They cannot swim yet. They do not have full ability. And once the sperm is moved from the testes, it goes into the epididymis. The epididymis will educate the sperm and make sure the sperm got mature and mature. And then along the body of the epididymis, when it gets to the tail, and now when it gets into the vas deferens, the sperm becomes fully mature. the sperm has ability to swim. So that's the sperm is being transported along the vas deferens, which is running through the external inguinal ring, along the inguinal canal, through the internal inguinal ring, going into the prostate, join with the seminal vesicle to form the ejaculatory tract, and finally open into the urethra, and this sperm can come out from the external urethral meatus. So that is the anatomy. This is the sagittal section. And so the prostate gland, which I was talking again and again about the prostate, or bulbourethral gland, look at that, which is at the base of the prostate, which is lying close to the massa urogenital diaphragm. These are GS secondary sex organs. So the primary sex organ is our testes. Okay, so, and this is the urinary bladder, and this is the rectum and anal canal here. And don't forget, our urinary bladder is outside the peritoneal cavity. So there will be a peritoneum between the bladder and the intestine. Yeah, so this is the diagram of the male reproductive system. So what about the female reproductive system? Female reproductive system, of course, this is anterior because we can see the pubic bone. We can see the sacrum here. And at the back, close to the sacrum, we have the rectum and anal canal here, And this is the urinary bladder, which opens into the, as the urethra, urethra. So urinary bladder open as urethra and cross the urogenital diaphragm. Urogenital diaphragm is here or here. Urogenital diaphragm is here, running from the posterior to anterior pubic symphysis. Urogenital diaphragm. Urogenital diaphragm is here. And look at that. There is no prostate gland in female. I believe you all know that. And this urethra came here at the opening of the opening in the vagina. It is as a external urethral orifice or external urethral meatus. So look at that, the length of the female urethra, which is very short. You know, the female urethra length is very short. And if we look at the male urethra, the length of the male urethra from the external urethral meatus into the bladder it is quite a long way to go. And therefore, the female, they are more prone to urinary tract infection because the cystitis quite common because the female urethra is very short. So female urethra is very short, therefore the female has more incidence of cystitis. And so posterior to the urinary bladder and urethra, we have the vagina and the uterus. Now look at the way the uterus is sitting. Uterus is sitting and folding anteriorly, lying on the urinary bladder, guys. So is it for everyone? Not really. No, but most of the ladies, especially before the labor, like before they got pregnant. So most of the younger women, or they are not pregnant, the uterus is bending forward if you compare to the vagina. That is what we call anteversion. So uterus is lying forward onto the bladder. So that is what we call anteversion. So this uterus is anteverted uterus, which is more common. I cannot say it is normal because retroverted uterus, if the uterus is folding and bending backwards, it could be normal. So anteverted uterus is more common, especially in those younger patients and those who hasn't had any baby yet. So undivided uterus. And the size of the uterus before pregnancy, for like nulliparous, so the lady hasn't had any baby yet, that size of the uterus is might be just about the size of the small orange, or might be a pear size. So it is really a small structure. I mean, it is amazing, you know, this uterus can expand to accommodate a baby, which is might be about like a few kg, like 3-4 kg, might be, you know, that's why the uterus muscle has got multiple layers, smooth muscles. Look at that, the thick, big muscles of the uterus. Although the uterus itself might be the size of the pear, or might be small orange, might be the small orange, which is lying and over the bladder, and that is what we call the anteversion of the uterus. And you can see the posterior fornix. So fornix are usually fall here, and in the front, anterior fornix. So these anterior fornix and posterior fornix are, it is something when you do the vaginal examination, you have to check this area, because it is some way you can easily miss. And look at the gland here, at the opening here, which is called vestibular gland. So, I mean, the female reproductive organs are very different from male reproductive organs. And now you can see the fallopian tube, which is coming into the uterine cavity and which is running here. So fallopian tube is not intraperitoneal. And the ovary here now, you can see the ovary here. Even the ovaries, they are not in the peritoneal cavity. So the ovaries are not intraperitoneal cavity, according to our textbook. Some books will say, you know, ovaries could be intraperitoneal. No, I don't think it is correct. Ovary is extraperitoneal. But when the ovaries ovulate, this little ovum being pushed out into the peritoneum, and these little fimbria usually come very close to the ovary. Once the little ovum pop out, these fimbria will go and catch. Of course, you know, it is not an easy process, and therefore, many times the ovum will get lost into the peritoneum and into the peritoneum. And yes, so therefore, you know, every ovulation might not come into the or fallopian tube. Hey, so this is the female reproductive organs, and now you can see the peritoneal folding here. So this peritoneum, which is covering the posterior abdominal wall, it just comes down here and it just extends into the space between the rectum and the uterus. Of course, that make a little pouch here. So we will call it rectouterine pouch. So rectouterine pouch is the space between the uterus and the rectum, rectouterine pouch. And the peritoneum will fold and cover the uterus. And this peritoneum will fold again and go invaginate between the uterus, anterior surface, and superior surface of the bladder. So, okay, so we have another pouch here. So this pouch is between the bladder and the uterus. So we will say vesicouterine pouch, vesicouterine pouch, and the rectouterine pouch. So why do I have to talk about these pouch? Of course, if you are a surgeon who is doing an operation in the peritoneal cavity, and if there is any pus inside the peritoneal cavity, you need to go and fish and go to that area and make sure you clean the pus inside the rectouterine pouch and vesicouterine pouch. So these are the little pockets where things can be left behind. So be careful with these pouches in the peritoneal cavity. Right, let's move on. Let's start with the testes, a male reproductive organ first, and then we will follow with the female reproductive organs. As we know, the testes will produce sperm, testes will produce hormone, and this hormone is androgen, mainly testosterone. We know that. So as we saw from the male reproductive organ, testes will produce sperm, and the sperm will be stored in the epididymis. From the epididymis, it will get into the continue into along as the ductus deferens. Ductus deferens along the ejaculatory duct. And then finally, it will come into the urethra, and it will come out as at the external urethral meatus. And we saw the accessory 6 glands, which are seminal glands, prostate gland, and bulbourethral gland. Yeah, so we have seen all these already. And the hormone from the testes, there is no duct. It just goes straight into the bloodstream. It is a ductless gland, and therefore it is called endocrine gland. Right. The scrotum and the testes. Let's talk about scrotum. Let's talk about the testes. So we know that we have 2 testes, right testicles, left testicle, and 2 testes are in the scrotum, but they cannot meet each other because there is a septum which is dividing the scrotum. So the right testis will stay in the right side of the scrotum, and left testes will stay in the left scrotum. They cannot meet each other. There is a partition in between. Why do we have to create a little pouch out of the body as a scrotum? Because the testes, although it was once intra-abdominal organ, it has to come out from the abdominal cavity and stay out of the abdominal cavity, out of the torso, and then sit inside the scrotum, because the testes doesn't like the temperature, body core temperature, which is 37 degrees. So the testes needs a little bit colder than the 37 degree, and therefore it has to come out from the abdomen and stay inside the scrotum. So testes likes the temperature of about 3 degrees lower than the core body temperature. So let's say about 34 degrees centigrade. So that it can, because it will function, it can function for the spermatogenesis. So for the sake of spermatogenesis, the testes has to come out from the abdomen and stay in the scrotum, and the scrotal temperature is about 3 degrees less than comparing to the core body temperature, which is about 37 degrees centigrade. And of course, you know, depending on the environmental temperature, if the environmental temperature is very cold, then the testes will have to go back closer to the body torso. So the dartos muscle, cremaster muscle will contract, and the testes will be pulled to the core body. And when the external temperature is too hot, and if our body temperature goes more than 37 degrees, the testes have to stay away from the core body. So the dartos muscle, cremastic muscle, we have to relax and then keep it away from the body. So the size of the testes is about, let's say 1 inch, 1.5 inch, so 2.5 by 4 centimeter. That's an average size. And testes is covered with the tunica albuginea. Albuginea, albu means white. Tunica means tunic, covering layer, white covering layer. So the testes is covered with the tunica albuginea. So tunica albuginea is firmly attached to the testes. Bang! We cannot separate tunica albuginea from the testes. So just if we split it, everything will fall apart. So because this tunica albuginea is firmly attached to the testes, and it's just invaginate into the testicle, going in and again in and again. And by doing so, this tunica albuginea is dividing the testes into multiple, like a wedge shape, different compartments, about 250 to 300 compartments. So this tunica albuginea is spiking into the testes and then separating the testes into to the different compartments. And outside the tunica albuginea, we have the tunica vaginalis. So this tunica vaginalis is nothing more than the peritoneal fold. So because, as we know, the testis has to come from the abdomen, has to go through the inguinal canal into the scrotum, and therefore, when the testis is going along its route, it takes the peritoneum like a blanket, and it takes the peritoneum along with the testes, and therefore, some surface of the testis is covered with the tunica albuginea, which is the peritoneum, which is made of visceral peritoneum and parietal peritoneum. So let's look at that, what I'm talking about. So let's concentrate here. Let's concentrate on the testes. This is the testes, and it is covered with the white, dense layer, which is the tunica albuginea. Yeah, look at that tunica albuginea of the testes. And outside the tunica albuginea, we have the tunica vaginalis. Tunica vaginalis is two-layer peritoneum, so parietal peritoneum and visceral peritoneum. And so if we bring the peritoneum inside, two layers of the peritoneum inside, we are taking the peritoneal cavity inside as well. So between two layers of the what's happened? What did I touch? Sorry, I touched something and there is.
All Saints Rehab.
Just 1 minute, please. Hello? Hey, Helen. Mm-hmm. 8B, okay. No, just wonder why is that, or no good reason, or? Oh, okay. So he has infection, or the other patient has infection. Oh. Okay, okay. All right. Okay. Thank you. Thank you. Oh, just 1 minute, guys. I'm not sure what's. Okay. Can you see the screen now? Yep, it is shared.
Yes.
Oh, thank you. Because this, I don't know what I did. I think maybe I touched one of the resume screen share. Okay, now, right. Sorry, that phone call was from my father's hospital. My father is in hospital, and I got a lot of phone calls. Okay, let's move on. So where is it? Where are we? So we are concentrating on the testicles. Yeah. So concentrating on the testicle, the white covering of the testes, which is called tunica albuginea. So look at the next. Look at that. The white outer layer, tunica albuginea, is going into the substance of the testes, and like a septum. And by doing so, it is creating multiple compartments. I mean, to be more precise, might be about 250 to 300 compartments inside the testes. So tunica albuginea, white, white, tunica mean layer white going into the testes. And this tunica albuginea just covers nearly every part of the testes. Yeah. So outside the tunica albuginea, we have a layer called tunica vaginalis. Vaginalis, it is the peritoneum. When the testes come out from the abdomen, going into the scrotum, it's pull the peritoneal cavity. So it is pulling the peritoneal cavity. So it takes two layers, both visceral and parietal layer of the peritoneum, and therefore there is a little space in between the two layers of the tunica vaginalis. So because that's the peritoneum. So let's go back to the previous slide, and you can see the pempaniform plexus of veins. Look at the vein pempaniform. It is very complex. Like, these veins can get varicose veins as well. Like I believe, you guys have seen varicose veins in the leg. So they are long, tortuous, dilated veins in the leg, especially like in these. So those people who has to stand up for the all day long, and if they do not move the leg, and if they do not pump out from the blood from the leg up to the heart, or like if the valves of the veins are damaged or they are not competent, then they can get varicosity. So this sort of varicosity can happen in this pempaniform plexus of vein as well. So what's happened is the pempaniform plexus of vein became dilated and tortuous and multiple veins, increasing the temperature of the spermatic cord and increasing the temperature of the testes, and that can damage the spermatogenesis. So wait, okay, let's stop there. That is what we call varicose. So let's stop there. You can see the pempaniform plexus of vein here, and you can see the vas deferens or ductus deferens coming along here from the testis epididymis, going into the inguinal canal, and then finally going into the pelvis and going to the prostatic urethra. And so now you can see tunica albuginea, tunica vaginalis, and the pempaniform plexus of vein, and all the contents of the spermatic cord. So now we have a scrotum and two testicles sitting in the scrotum, and there is a septum here in the septum hole. Here, septum of the scrotum. So right testes cannot meet left testes. That's a sad thing. They are very close, but they cannot meet each other because of the septum. And now we have to appreciate the anterior abdominal wall muscle again. Oh my God, yeah, oh my God. This comes again and again and again and again. So what are the structures covering the testes? Of course, we know the skin. Skin is one of the covering layer of the testes. Okay, so shall we a little bit elaborate more about the scrotal skin? So just look at that. Number one is scrotum. The outermost layer covering the testes is called the scrotum. Scrotum is not just the skin. It also contains the dartos muscle. So scrotum is made of skin and the dartos muscle. Dartos muscle, so these are the, which is mixed with the superficial fascia. So the skin and the dartos marcel, which is superficial fascia, it is called the scrotal skin. So our scrotal skin is not just the skin, it also have the dartos marcel. Yes, so scrotum is made of skin and dartos marcel. So that's the very first layer. If we make a cut on someone's scrotum, the first layer we cut is skin and dartos marcel. And the second layer is external spermatic fascia. Hey, look at that, external spermatic fascia here for the right side and for the left side. What is external spermatic fascia? External spermatic fascia is the continuation of the external oblique aponeurosis, guys. So it is simple, yeah? It is simple. External spermatic fascia is the fascia continuation. Look at that. This is the external oblique marcel and external oblique aponeurosis, which is splitting into V shape, creating a external ring of the inguinal canal, and this external oblique continue into the scrotum and providing a external spermatic fascia. Look at that, that's wonderful. And let's say if we keep opening the external spermatic fascia, we will get to a little bit more marcel-like structure. That is what we call cremaster marcel. What is cremaster marcel? Again, like cremaster marcel is the continuation of the internal oblique, guys. So all these external oblique, internal oblique, and transversus abdominis are just following even into the scrotum. Yeah. So the cremaster marcel here you can see, which is the internal oblique marcel here. And then keep going into the internal spermatic. Let's say if we remove the internal spermatic fascia, cremaster marcel, and now where is the internal spermatic fascia? Hey, look at that, number 4, 1, 2, 3, and the number 4 layer is internal spermatic fascia. Look at that. What is internal spermatic fascia? Because we said external spermatic fascia is external oblique, cremaster marcel is internal oblique, and we might think internal spermatic fascia is continuation of transversus abdominis. So external spermatic fascia is external oblique, cremaster marcel is internal oblique, and transversus abdominis doesn't follow into the scrotum. Hey, this guy is a little bit naughty, yeah? So the two marcel and fascia layer anterior to it follows into the scrotum, but transversus abdominis doesn't follow. So what is this internal spermatic fascia made of? It is the last layer from the abdomen, which is before the peritoneum, which is the transversalis fascia. Transversalis fascia is continuing into the scrotum as the internal spermatic fascia. Right, so these are the layers. Then once you open the internal spermatic fascia, you will get to the tunica vaginalis, which is 2 layer. There is a space in between the visceral and parietal layer, and after the tunica vaginalis, we go to the tunica albuginea. So that is the covering layers of the testes. From outside, the scrotum. The scrotum is made of the skin and the dartos marcel, and then followed by the external spermatic fascia. External spermatic fascia is continuation of the external oblique aponeurosis. After the external spermatic fascia, we go to the cremaster fascia, cremaster marcel. Cremaster marcel is the continuation of the internal oblique aponeurosis. Then after cremaster marcel, we go to the internal spermatic fascia. Internal spermatic fascia, we expect the transversus abdominis to follow as the, but it is not. It is the innermost transversalis fascia, continuation of the transversalis fascia, and finally we go to the tunica vaginalis, which is the two-layer, which is the viscera and parietal peritoneum, and finally we go to the something stick and invading into the testes, which is the tunica albuginea. Bang. Okay, then I'm going to go one more slide before I give you a break. And look at that. This is the scrotal swelling. Yeah, swelling in the scrotum. Scrotal swelling. Scrotal swellings are important, like especially if you're working in the surgical unit or urgent care, emergency. So people tend to present as an emergency or might be like a long-standing problem, like a scrotal swelling. So scrotal swelling means once we see something, we need to have differential diagnosis. What are the possibilities? Differential diagnosis. So it could be like fluid in between the viscera and parietal layer of the tunica vaginalis, excessive fluid accumulation. That is what we call hydro-C. Hydro means water, C means collection of fluid, hydro-C means fluid collection in the viscera and parietal layer of the tunica vaginalis. So that is what we call hydro-C here. And look at that with the bruising. So there might be accumulation of blood in the scrotum. That is what we call hemato-C. So collection of blood in between the viscera and parietal layer is called hemato-C. Of course, there might be a history of scrotal injury. Or varicose-C. Varicose-C, we saw that our pempaniform plexus of vein getting bigger and tortuous and dilated. That is what we call the varicose-C. And hernia, so the intestinal contents can follow through the deep ring along the inguinal canal, come out from the superficial ring, and finally go into the scrotum. And so these intestinal contents can tie the scrotum as well. That is what we call hernia. And finally, of course, the tumor arising from the testis itself. That is what we call testicular tumors. So that's why it is really important to know the layers of the scrotum, contents of the scrotum, and what can come into the scrotum. Right, so just before I'm going to show you one more slide. The testes, tunica albuginea, which we just go into the substance of the testes. When doing so, it is creating multiple lobules here, and as I say, like there could be like 250 to 300 lobules in one testis, and inside the lobules we have the little tortuous tubular structures, which is called the seminiferous tubule. Look at that seminiferous tubule here. This seminiferous tubule, they are really tightly packed inside the testes, and then once they become straight, we will call that straight tubule. Straight tubule. And straight tubule will combine, many straight tubules will combine, and then finally become a plexus of tubules. That is what we call rectus testes, rectus testes. So don't forget the order from the seminiferous tubule, which is located in the lobule divided by the tunica albuginea of the testes. Seminiferous tubule, which is here, seminiferous tubule, which will become straight, that is called straight tubule, finally combine as the rectus testes, and these rectus testes will open into the head portion of the epididymis. And epididymis will gradually tortuous and dilate and gradually educate the sperm inside, and then finally got to the tail of the epididymis and gradually keep going and then finally become vas deferens. That is the That is the pathway of our sperm. Right. Okay. So it is like 6:11. Shall we take about 10 minutes break? So we take about 10 minutes break and we will meet. Okay. Right. So that is the seminal gland. And we have to, so just sit tight, guys. Please stay a little bit early. And prostate gland, we saw that prostate gland, male have prostate gland, female do not have prostate gland. It is just sitting at the base of the urinary bladder, and it is like a tubulo-alveolar gland. Tubulo-alveolar gland. So alveolar means little stroma and tubular structures. And it has got three portions: main, submucosa, and mucosa gland portion. Its prostate gland constitute about 1/3 of the semen. So 60% of the semen is from the seminal gland. 1/3, so 30% of the semen is about from the prostate gland, and its secretion contains PSA. What is PSA stand for? It is prostate specific antigen. Prostate specific antigen, which is really important when we are talking about the prostate cancer. So in prostate cancer, this PSA, prostate specific antigen, goes far way up. If we have a big prostate, like when the man get old, our prostate gland will get bigger and bigger. The big prostate, so prostatic hypertrophy or hyperplasia, will produce more prostatic specific antigen. But if we have prostate cancer, this prostate specific antigen goes far way up. So this is the prostate gland. So let's look at the prostate gland. So as we say, it has got three main portions: mucosa glands, submucosa gland, and the main gland, so prostatic glands. It is a fibrous tissue and smooth muscle stroma, and it is covered with the connective tissue capsule. And in the middle of the prostate gland, we have the prostatic portion of the urethra. And prostate is only present in male, not in female. Right. So bulbourethral glands. So these are small little accessory glands, and it is in the urogenital diaphragm. We saw that little, and it neutralizes the acidity of urine. Of course, you know, after so the urethra might be filled with the urine. So that urine has acidic, and when during the ejaculation, the sperm come out, and sperm does not want to mix with the urine because urine is acidic. So this acidic urine need to be neutralized, and this bulbourethral gland will neutralize the acidity of urine. And this is the portion of the penis, which is divided into root, body, glands, and foreskin prepuce. And remember, point and shoot. I believe we will talk about that in the autonomic nervous system. Point and shoot. What is point? What is shoot? Point is for parasympathetic. Arousal, like erection. Pointing is originate the nerve supply for the responsible for the erection is parasympathetic. Shoot, shoot, sympathetic, mean ejaculation is sympathetic. Okay, guys, so point and shoot. Remember, point and shoot. Point mean erection. Parasympathetic the nervous system is responsible for the erection, and shoot, ejaculation. Sympathetic nervous system is responsible for ejaculation. And so now let's move on. So the different portion of the penis, and what is more important is the urethra. This is the urinary bladder. At the base of the bladder, we have the prostate gland. The urethra go through the prostate gland as the prostatic urethra, and then in the muscular portion, urogenital diaphragm, where we have the little bulbourethral glands, And this portion of the urethra is called intramembranous urethra. And finally, it is called the spongy urethra and come out as the external urethral meatus. And if you do a cross section of the body of the penis, we will have this structure. So let's look at this. Like our urethra is running in the corpus spongiosum. Corpus spongiosum. Our urethra is running in the corpus spongiosum. And on either side, we have the corpora cavernosa. Corpora body. Cavernosa means venous cavern, venous cavity. So these corpora cavernosas are filled with the deep arteries in the center and filled with the veins around. So when there is the erection, this corpora cavernosa is filled with the venous blood here. So that is the importance of the body of the penis. Cross section, I want you to remember corpora cavernosa. Corpora means body, cavernosa, cavernous, like little cavity, venous cavity here. In the center, we have the deep arteries of the penis, and dorsal artery and dorsal blood vessels enough there on the back of the penis. And urethra is in the corpus spongiosum. Corpus spongiosum is, urethra is in the corpus spongiosum. So that is the end of the male reproductive system and male external genitalia. And I just want to take a little bit more of the female reproductive system so that when we start on Monday about the female reproductive system, we have a little bit easy start, yeah? And we'll take about another 15 minutes to talk about the female reproductive system. Is that all right? Yeah. So female reproductive system includes ovary and accessory organs. Ovary is the primary sex organ. Female primary sex organ is ovary. And secondary sex organs are uterus, uterine tube, vagina, and vulva. Okay, so I believe we have seen this already. The bladder is in the front, rectum is in the back. In between the rectum and the uterus, we create a pouch, which is called recto-uterine pouch. In between the bladder and the uterus, we create another pouch, which is what we call vesicle. Vesicle means bladder, and uterus, vesico-uterine pouch. Right, so vesico-uterine pouch and recto-uterine pouch. So for the male, of course, male do not have the uterus, so we will only have recto-vesical pouch. Yeah, so in male we have recto-vesical pouch. We have talked about all these structures in the female already, but let's say this is the sagittal section. Let's look at from the front. Coronal view. So now this lady is giving back to us. So this is the right and this is the left. We are looking at this lady from the back, and this is the right, this is the left. Always think about anatomical position. And we said we have two ovaries, left ovary and right ovary, right fallopian tube and left fallopian tube. Fallopian tube leading into the uterus and uterine cavity. Uterus has 3 layers. It is not a big surprise. 3 layers. They are innermost, close to the cavity, endometrium, marcel layer. Look at that, very thick marcel layer, which is myometrium, and outermost layer, which is the perimetrium. So perimetrium is just the outermost adventitial layer. So 3 layers of the uterus, endometrium, myometrium, and perimetrium. As we said, the uterus is not big. It is just a small, like a little orange. So uterus is a small structure which is lying forward, anteversion, And the fallopian tube, we know that the fimbria and the first portion of the fallopian tube is infundibulum, and gradually become ampulla. And if we go along, just before it goes into the uterine cavity, that portion of the fallopian tube is called isthmus. Isthmus. So isthmus is the smallest portion, and if somebody get ectopic pregnancy along the fallopian tube, it is the isthmus portion, usually isthmus portion, because the ampulla is wide. Ampulla and infundibulum, this is the site for the fertilization. And this fertilized ovum has to travel along the fallopian tube. The closer it gets to the uterus, it becomes narrower and narrower. The isthmus portion is the narrowest, and therefore it is the site where the this little fertilized ovum gets blocked, which is called ectopic pregnancy, which is most common in the isthmus portion of the fallopian tube. And this fallopian tube, they are covered with the peritoneum. They are outside the peritoneum, so extra peritoneum. These anterior fold of the peritoneum and posterior fold of the peritoneum stack together to form the mesosalpinx, salpinx being fallopian tube, mesosalpinx, and to form the ovarian ligament, to form the mesometrium. So these are the, look at that, lateral cervical cardinal ligament. So these are the anterior and posterior folds of the peritoneum. So peritoneal sheath, they just overlap and then just squeeze them together. So they become the ligament and folds of the uterus and fallopian tube and vagina. That's what's happened. Right. Can I move on to next slide? And you can see the different portion of the uterus. The dome portion is called fundus of the uterus, and this is the body of the uterus, and this is the cervix portion of the uterus. Cervix portion has external cervix, which is just opening into the vagina, and cervical canal here you can see, and we have the internal cervix, internal os, which will lead into the uterine cavity. Yeah, so internal os, cervical canal, external os, and the vagina. Ovaries are pair organ, right ovary and left ovary. The size of the ovary is just about 1 to 3 centimeters. It is a retroperitoneal organ. It is outside the peritoneum, and it is hanged by the suspensory ligament and ovarian ligament. So look at that, it has got cortex and medulla. Look at that ovary here. This is the ovarian ligament here, and this is the broad ligament, which is made of mesosalpinx, mesoovarium, and mesometrium. So this broad ligament, big broad ligament on the side, look at the broad ligament here, which is made of mesosalpinx, mesoovarian, and mesometrium, which is on the side of the uterus and enveloping the ovary. These, because of all these, ovary can stay in that position. All right. So this is the last slide. Ovary has got cortex and medulla. In the medulla, like everything, like adrenal gland has got cortex and medulla. Thymus, we have cortex and medulla. Kidney, we have cortex and medulla. Cortex means outer portion, medulla means inner portion. Inner portion of the medulla, what do we have? We will have the blood vessels and nerve. Outer portion, cortex, we will have the little ovaries, which is little ovum, which is situated in the follicle, which is what we call ovarian follicles. These ovarian follicles will gradually develop and get mature, and each and every cycle, mid-cycle, this ovum from the follicle will pop out from the ovarian cortex, That is what we call ovulation. All right, I think I better stop here so that we will complete this reproductive system on Monday. So Monday we will continue the reproductive system. Has anyone got any question? Is anyone stay around? I believe you guys are. All right then. All right then. In that case, I will let you go. Have a good weekend. And I will meet you on Monday. We will continue reproductive system from the female reproductive system. Yeah?
Thank you.
All right, Alexandra. Yeah, you will stay here.
Thank
All
you.
right. Okay, guys.
I did have a question. Is Wednesday going to be a review day then, or are we not doing that?
Wednesday will be a review day. Like we'll talk what we have learned during the October time.
Okay.
So those lectures from end of September exam to obtain now. And we will not have class on Friday. Yeah.
Okay. Thank you, Professor.
All right, guys.